who is a stool liver like a feeler, and she's asking me about Dr. Lederman's treatment because she does have brain cancer, and she's a noted star. I don't want to mention her name, but she is possibly going for treatment with Dr. Lederman. And they have several other people that have it, which are unknown, which are business people in the area.
Well,
and
no one's more of a star to us than you.
Well, thank you very much, Doc.
And I appreciate your call and relating what's happened to you.
It's a pleasure to call, Doc, and God bless you. Thank you very much. You've given me hope, and you've given me life again.
All right. God bless you. Have a great weekend. Enjoy the great weather.
Right.
We're going to hear from our sponsor, and then we'll be right back with more news and more calls and more patients. Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board-certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WABC studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. Hey, Dr. Lederman, we're back.
Hey, we're back. This is Dr. Lederman. We're taking your calls just like we took our last patient's call. We're happy to speak with you. There's news, and this news is very applicable maybe to 250,000 Americans. And I just had a patient with the same issue, and it may be important to you or your loved ones, maybe if not today, maybe tomorrow or another day. There was a report published in the medical journals, Journal of Clinical Oncology, which is a big cancer journal. And the whole topic was how much of the breast needs to be removed when a woman has breast cancer. Now, if you want to save your breast, and we have another report later in the show or another show this weekend. We have 5 shows. So if you want to listen to the other shows, the other ones on Sunday are on WOR, and they start at 1:30 and 3 a.m., and then a live show at 6 a.m. and 9 p.m., which we're going to talk about more of this topic. But the question is, if a woman has breast cancer, how much of the cancer and the surrounding tissues should be removed? Well, the answer simply is the cancer should be removed. And as long as the cancer is removed, when the surgeon takes out that cancer, he should roll it around in ink, and then the pathologist, who's a doctor that looks at the cancer under the microscope, looks to see that there's no ink on the cancer, which means that the surgeon has removed all the cancer but a minimum amount of healthy breast. Because, heck, if he starts removing more and more of the breast is going to be deformed. The breast is like any other organ or tissue. Let's just say you have a bag of silicone, and in the middle of that is a marble, and the marble represents the cancer. Well, if they remove the cancer, that's great. If they remove a lot of the healthy tissue, the surrounding tissue, the breast will be smaller, the breast will be deformed. Now, sometimes there's a conflict of interest because maybe the surgeon wants to do a second operation for whatever reason. Maybe he thinks it's better, maybe he makes more money, whatever the reason is. So the surgeon's motivation may be great, and we hope that it is. But often we see patients, I just saw a patient this week who had negative margins. and the surgeon wants to do a second operation. Well, we know the second operation is going to be deforming because all the cancer's already been removed with negative margins. And he told the woman, well, if you go to XYZ, this is enough, but I believe you should have a second surgery. So it puts the patient in a position where she has to tell the surgeon, no, I think you've done enough. Stop. And so it's a conflict, a little conflict here. And so what am I talking about? Well, I'm talking about how much breast to remove when you have breast cancer and you want to save your breast. So the primary recommendation, this was by a surgical society, a radiation society, and the chemo society for cancer, is that there's no ink on that cancer. So the surgeon needs to roll it around in ink, send it to the pathologist. The pathologist reviews it, and he tells whether or not the cancer's been fully removed. That's the standard of care in America, that there's been adequate removal of that invasive cancer, is that the ink is not on the cancer. Now, if you get more and more margins, let's say it's a centimeter, which is about a third of an inch, or a centimeter and a half, you're going to end up losing a lot of the breast, and you can't really replace the breast in the same way God gave you that breast. And if a surgeon says, well, I got the cancer, but I want more margins, there's no reason. Just say no. And the ASCO panel, which is the group of American Society for Chemotherapy Doctors, agreed that the recommendations are clear and based on the most relevant scientific data in the area, and they represent and present options acceptable to patients. The recommendations are that positive margins, if there's ink on the invasive cancer, does have an increased risk of recurrence of the cancer. So if there's a positive margins, yes, you should go back and have that margin turned negative. But if there's a negative margin, it's enough. The recommendations are negative margins, no ink on the cancer, optimize ipsilateral, that breast cancer treatment. And to be very clear, they say wider margins do not significantly help. It's very clear. How can we make people understand? It's very, very clear. So, larger margins don't help. Any margins are perfectly fine. Either you win or you lose, and by doing an unnecessary surgery, you don't help yourself. And there's another study out showing that women who have lumpectomy and radiation to save their breast actually have a higher chance of being cancer-free than those who have mastectomy. And I know many people believe if you remove the whole breast, you have a less chance. It's not true. It's not true that removing the whole breast, I'm talking about for the typical woman, I'm not talking about everyone. There's always exceptions, and we'll talk about them, or they can call us for a second opinion, and I would urge people to call us for a second opinion. Removing the whole breast for the typical person does not improve your chance of being cancer-free. It just doesn't. So if you have questions about this, give us a call. We're happy to speak to you. We don't want you to do the wrong thing. We want you to do the right thing. And another case this week. This is a gentleman who came in. He's 87 years old. He's married. He's an Italiano, an Italian stallion, married to a Filipino nurse, loving marriage. He had esophageal cancer. He had surgery, standard chemo radiation a year ago. And now the cancer's back in the esophagus. He wants to know if we can treat with radiosurgery. We wanted to stage him up. We found where the cancer is, and the cancer has progressed in him. So it meant that the standard chemo and radiation didn't work. He's now got this mass in the esophagus and some other tumors. He wants to be treated. He wants a chance to shrink down that cancer non-invasively. He wants to eat and be normal. He came in this week. I spoke to his wife. I spoke to him. I spoke to his niece, who's loving, and he decided to go ahead with treatment. He came in yesterday to see if we're ready to treat him, and we treated him. It took 15 minutes. He was in and out, had his treatment, and we hope today his cancer is shrinking. We're working for that. We had a busy week with prostate brachytherapy. Brachytherapy is putting radiation seeds in the prostate. Why put radiation seeds in the prostate? Well, why did Willie Sutton rob banks? Remember, Willie Sutton used to rob banks and finally was caught by the police. And the police says, why do you rob banks? And he said, that's where the money is. That's a pretty good answer. Why do we put radiation into the prostate? That's where the cancer is. If you can put the radiation where the cancer is, you can avoid all the other structures. You give a hefty dose of radiation to the prostate. The treatment takes about 45 minutes. It's a proven track record. It works. We did multiple cases this week. We had one man who went to another facility first, and the nurse said, oh, my husband had it, and you're going to be in pain and suffering and burning and bleeding and blah, And he was so worried. He decided to come to us because he liked our data. We have data. If you call in and ask for our prostate booklet, we have our data of 3,000 men treated versus other centers, and you can see exactly where you stand with our treatment versus robots and human hands and blah, and 9 weeks of treatment. And you'll see in essentially every category, our patients do better. What does it mean? It means you have a better chance of being cancer-free. So he saw our data. He came in and chose to come with us. Well, this man was the world's most skeptical man. He'd call me in the morning and the night, and he was so nervous, and he wouldn't like how people looked at him. And we nursed him through. We gave him, he was an intermediate risk, he had a Gleason 7 cancer, and we know the best treatment for Gleason 7 is a short course of external radiation in the stereotactic frame, like John explained, and then brachytherapy. And he was prepared, he was prepared for an atomic bomb to hit him. He came in Monday at 8 o'clock, 8:30, and we treated him on time. By 10:30, he was feeling great and left. And he called me the next day, and he called me the next day, and the next day, which means Tuesday and Wednesday and Thursday. And he said, Doc, I didn't feel a thing. And that's what you're supposed to feel. You're not supposed to feel a thing. He said the other place they shocked him and they gave him narcotics and No, we put the seeds in. There's a little needle. We poke the seeds in. We have computerization. We know where the seeds belong. We give radiation seeds in the prostate. They go through the skin directly into the prostate. There's no cutting. There's no suturing. It takes about 45 minutes. The patient doesn't feel a thing. We numb them up, get the seeds in. We then do a scan to prove they're on the right position. And then the patient urinates and goes home. It's so simple compared to radical prostatectomy where someone's hands are in your body, where best rates of success for Gleason 7 cancer are about 60-65%. With us, it's 90%. Where would you want to be? 60% success hospital or 90% inpatient avoided? Walk in, get your treatment, walk out, and go to Macy's. Where would you want to be? I'd want to be in the 90% group. So we had multiple patients this week. Every patient did great. You know, the readmission rate for surgical patients is about 10%. 10% of people who have radical prostatectomies have to go back in the hospital for complications. You know what percent of our patients have to go in the hospital? Yeah, you got it, about 0. So give us a call if you want. Our number during the week is 212-CHOICES, 212-246-4237, 212-246-4237. We'll talk more. We'll send you the booklet, and you can decide yourself, which is what you should do. You're the president of the United States of your body. Now we're going to have some more voices about our work, and we'll be right back. If you want to speak to us on the show, you can call us at 800-848-9222.
For cancer treatment, most prefer effective, non-invasive, well-tolerated outpatient therapy. With Dr. Lederman, the radiosurgery pioneer, that's our goal, too. He's first in America, first in New York, first for you with body radiosurgery. We hit your cancer with no cutting, no bleeding. Dr. Lederman has decades of experience